Good afternoon, everyone. My name is Molly Alawade, and I'm the Director of Education here at the American Kidney Fund. Thank you for joining us today for our webinar, What You Need to Know About Nephrotic Syndrome. This webinar is brought to you by Mallinckrodt, and we are grateful for their support. Before I turn the presentation over to today's speaker, I'd like to direct your attention to the control panel you should see on your screens. All participants are on mute, so we won't hear you, but we welcome your questions. If you have a question, please type it into the Q&A box. We'll see your questions and we'll do our best to answer them by replying to you in the Q&A box or out loud during the last several minutes of the webinar. For those of you in attendance who are health professionals, we are glad that you've joined us today and hope you'll recommend this webinar to the patients you work with. However, as a friendly reminder, this webinar is not accredited for continuing education credits. If you believe that your accrediting body may offer you credits for attending this webinar, we'll be happy to send you a certificate of attendance after today's session. Simply email us at education@kidneyfund.org. Without further ado, allow me to introduce today's speaker, Dr. Samira Farouk. Dr. Farouk is a transplant nephrologist, Associate Program Director of the Nephrology Fellowship, and Social Media Director of the Division of Nephrology at the Icahn School of Medicine at Mount Sinai, or ISMMS. She is a graduate of Princeton University, where she received her Bachelor of Science in Engineering in Chemical Engineering with a certificate in Spanish and Portuguese language and culture. She received her doctorate from Rutgers University Robert Wood Johnson Medical School, where she graduated with a distinction in research. She completed her internship, residency, and nephrology and transplant fellowship at ISMMS and served as chief fellow. Dr. Farouk's research interests include understanding pathogenetic mechanisms of kidney fibrosis and predictors of allograft survival. She is a member of the Tango International Transplant Consortium, whose goal is to study the recurrence of glomerular disease after transplantation, and now novel coronavirus in kidney transplant recipients. She is interested in developing and studying innovative medical education tools, and is the co-founder of NephSim, a mobile optimized nephrology teaching tool. Dr. Farouk is also co-faculty lead of the Renal Fellow Network. Thank you, Dr. Farouk, for joining us. I'll turn the presentation over to you.
Hi, everyone. Thank you, Molly, for that kind introduction. As Molly mentioned, my name is Samira Farouk, and I'm a transplant nephrologist at Mount Sinai in New York City. Very happy to be here today with all of you to talk a little bit about nephrotic syndrome and potential implications for patients with kidney transplantation and what we should think about with respect to nephrotic syndrome in patients after transplantation. And so I have three overall objectives for our session today. And the first will be to review the causes of nephrotic syndrome and some of the symptoms that it may present with in individuals that are affected. Second is to discuss a bit about the risk of nephrotic syndrome post-transplant. This is a syndrome that can occur not only in patients prior to transplant in their native kidneys, but also in the allograft kidney transplant that patients will receive. And finally, I'm hoping to emphasize to you all the importance of follow-up visits after a kidney transplant and how we can use information from those visits to assess an individual's risk for nephrotic syndrome and to discuss what we might do if we do find nephrotic syndrome in one of our patients after transplantation. Next slide, please. And so what is nephrotic syndrome? And so in medicine and clinical practice, we have this word that we use called syndrome is not necessarily a disease that causes something else, but a syndrome is what we refer to as a group or constellation of different symptoms that fit together that may be caused by many different disease processes. And so similar to other syndromes, nephrotic syndrome is a group of symptoms that indicate some sort of damage to the kidney. And I'll go into a little bit more about what type of damage that is a bit later in our session today. But the main symptoms of nephrotic syndrome are primarily driven by one, too much protein in the urine, And so if the kidneys are working normally, we should not have a lot of protein in the urine. And the word that we use to describe that, you can see on the right-hand side here, is called proteinuria. And there's a number that as kidney doctors that we use as a cutoff for what we think is part of the nephrotic syndrome versus what is not. And so that number that we use is we can actually quantify the amount of protein that someone has in their urine. And that's a simple urine test. We take a small sample of the urine and send it to the lab, and they're pretty quickly able to tell us how much protein is there. And we tend to describe that in grams that are present in the urine over a 24-hour period. And so any of you that may have seen a kidney doctor in the past, your kidney doctor may have asked you to give one urine sample or to ask you to collect your urine over 24 hours. And both of these tests are effective ways for us to measure the number of grams of protein that an individual is putting into their urine over a 24-hour period. So when that happens, that can lead to several downstream effects and other symptoms that make up the nephrotic syndrome. And so in addition to having a high amount of protein in the urine, these individuals that have nephrotic syndrome also may have low levels of protein in the blood. And so you can see that here as albumin, and the word that we use is hypoalbuminemia, and that basically just means low protein in the blood. And so we have a lot of protein in the urine, not enough protein in the blood, and those two symptoms together can lead to increases in the fat or the cholesterol in our blood. And so that can also be measured by a simple blood test. And the lack of protein in the blood, as well as having too much protein in the urine, can lead to swelling. And so that swelling can be seen in the legs, it can be seen around the eyes. Overall, the individual may feel very puffy. And when we see all of these symptoms together, a lot of protein in the urine, not enough protein in the blood, high cholesterol or fat in the blood, as well as swelling, together, we might say that that individual has nephrotic syndrome. And once we have made that decision, the next step is to try to understand what is the disease that is causing that nephrotic syndrome. And that's important because the disease will help us choose different treatments that might be effective in potentially reversing the process. And the last symptom that is not mentioned on the left side here, but is in the graphic on the right side, is that individuals that have nephrotic syndrome also have a predisposition to forming clots in the blood, or having blood that's a bit thicker. And those clots can affect the legs, they can affect the lungs. And so when someone has nephrotic syndrome, we might also think about what is their risk of blood clots, and that's an important part of a potential treatment plan. Next slide, please. And so again, a more simplified graphic here that's essentially showing that protein in the urine, or a large amount of protein that spills into the urine, is kind of the underlying factor that leads to that constellation of syndrome that we describe as nephrotic syndrome. And just to review again, high levels of protein in the urine, low levels of protein in the blood, high levels of fat in the blood, and a predisposition or more likelihood of forming blood clots. Next slide, please. And so taking a step back, why do individuals develop nephrotic syndrome, and why is there so much protein in the urine? And so I've already told you that protein in the urine should not be there. If someone has a normal functioning kidney, we should not be able to detect or find large quantities or concentration of protein in the urine. And so this graphic here is a kind of zoomed in view of one of the mini filters that are present in the kidney. And so overall, the kidney we see as kind of a super filter. And each of these units here, so this unit that we have zoomed in here is called the glomerulus, and the kidney has about 1 million of those in a normally functioning kidney. And so one way that I like to think about this filter and how I describe it to patients is that the glomerulus is like a coffee filter that you might use when you're making coffee in a coffee machine. And so to do that, you would put the grounds in the filter, you would put water, and the water would come through the filter and to kind of bring out that coffee flavor. But we all know that we have the filter in place so that the coffee grounds themselves don't end up in the coffee. And so if we think about the coffee grounds like protein and the coffee filter like the glomerulus, I think that's a nice analogy to describing nephrotic syndrome. And so on the right side here, we have depicted a normal coffee filter that is holding all of the grounds in place. And in an individual with nephrotic syndrome, you might imagine that there might be holes in the bottom of that filter, a lot of grounds coming through into the mug. And so that would be an example of a patient with nephrotic syndrome having a lot of protein in the urine due to damage of this filter here. And if you can appreciate, you can see these yellow cells that are overlying the blood vessels, which are marked by red, and there's a little purple circle in the middle, which is the nucleus. That is kind of one of the most important filtering cells that the kidney has, and that is called a podocyte, and we'll come back to that a bit later. And one thing that all nephrotic syndromes have in common is significant damage and injury to that podocyte cell, and that podocyte is the very important cell for keeping our coffee filter intact. And so if our podocyte is damaged, then you can expect that we'll have a lot of coffee grounds and protein that will be spilling into the urine and causing this nephrotic syndrome. Next slide, please. And so again, podocytes are an important part of the filter that are damaged in patients with nephrotic syndrome. And you can see on the left side, the arrow is pointing to a microscopic view of these podocytes. And you can see that they're all kind of standing up like little game pieces. There's a little bit of a space between them, and they all seem to be separated. And so this is a healthy appearing filter. And so this would be a normal coffee filter, and I would not expect to see any protein in the urine of this kidney. Comparing that to the kidney on the right, you can see here that we've lost that space between the podocytes that appear to be a bit shorter and flatter, and they also seem to be touching each other. And so the word that we use to describe that is effaced. And so these are flattened, effaced, injured podocytes that are not going to be an effective filter and are not going to be providing a way for the kidney to keep the protein out of the urine. And so this kidney, I would imagine to have a lot of protein in the urine because of damage and flattening and effacement of these podocytes. And again, if we compare the healthy looking podocytes that are standing tall and upright on the left compared to the right, the podocytes are flat, looks like something maybe kind of rolled over them or squashed them, and these are injured podocytes and are not going to provide an effective filter for us to keep protein out of the urine, which is one of the goals of this filtration structure that we have in our kidneys. Next slide, please. And so I see a question here of what is the difference between nephrotic and nephritic syndrome, and we'll come back to that towards the end of the talk. The short answer to that is that nephritic syndrome, the predominant feature is not significant amount of protein in the urine. And so for that reason, nephritic syndrome is a bit different. And so what are some different causes of nephrotic syndrome? And so for most kidney diseases, we like to separate these into what we call primary versus secondary causes. And so what does that mean? So primary means that it is a disease process that is really affecting just the kidneys. And so our treatment strategy really focuses on what is happening in the kidney and how can we stop or reverse that process in some way. And two examples of primary kidney diseases that only affect the kidney would be focal segmental glomerulosclerosis, and so you may have heard this referred to as FSGS, and another example of that is minimal change disease. And so what we mean by primary is that other organ systems such as the liver, the heart, are not affected, and only the kidney is the one that is really having injury. And these two diseases, FSGS and minimal change, would lead to injury to the podocyte, that important filtration barrier in the kidney, and that would ultimately lead to a nephrotic syndrome, leading to loss of significant amounts of protein in the urine, low protein in the blood, and the other changes that I described. And secondary means that there is a disease process that is affecting the kidney, but other organ systems and parts of the body as well. And so our treatment strategy here would focus on treating that, what we call the underlying disease. And so a common example of that is diabetes, which is not a primary problem with the kidney. Diabetes happens because of a problem to maintain normal glucose levels, and the kidney does not have a direct role in doing that. However, when an individual has diabetes over a longer period of time, those changes can affect the kidney and lead to nephrotic syndrome. And the treatment in that case would be to try to improve the glucose levels rather than trying to affect a process that's specifically happening in the kidney, as we would do for a patient that has FSGS or minimal change disease. Other examples of secondary causes of nephrotic syndrome are lupus, which can affect the kidney as well as other parts of the body like the skin, the lungs, the heart, the joints. Another example would be HIV, which is an immune system problem in which the immune cells do not work normally. And that problem, though not primarily driven by a problem with the kidney, can cause significant damage to the kidney and is one potential cause of nephrotic syndrome. Next slide, please. This is a diagram that we often use to try to categorize causes of nephrotic syndrome. And this is a way that a kidney doctor might kind of think about potential causes of nephrotic syndrome in an individual that presents with these symptoms. And so on the left side, you can see in red primary, and on the right side in red, you see secondary. And then below that are various causes of primary kidney diseases compared to secondary kidney diseases. And a kidney doctor might use other information from the patient, including their medical history, any exposures they have had, any history of infections, any known history of cancers, any known history of medications that they may have used in the past. And that information, in combination with possibly a kidney biopsy when we feel that may be helpful, can be used to really pinpoint what is the most likely cause of nephrotic syndrome in that patient. And this distinguishment between primary and secondary is incredibly important because the treatment strategies are very, very different. And again, coming to that example of secondary nephrotic syndrome from diabetes on the right, the treatment for that would be to improve glucose control or the levels of sugar in the blood, compared to a primary disease such as focal segmental glomerulosclerosis or FSGS, in which the primary treatment would be a medication such as steroids or a medicine that would help decrease what's actually happening in FSGS. And so when a patient presents with nephrotic syndrome, it's very important for us to gather as much information as we can from the patient to try to understand whether or not this is a primary process versus a secondary process. So there's a question in the chat from Jenny Tang that's asked, is there any test to indicate that your podocytes are affected? So the most effective test to understand if the podocytes are affected is to look at the amount of protein in the urine. And so anyone that has a lot of protein in the urine, that is a large clue that the podocytes are likely injured. And the more definitive way to see if podocytes are affected are to do a kidney biopsy. And then you would see the image that I showed you in the previous slide. Next slide, please. And so again, just to review and show another graphic, what are the signs of nephrotic syndrome and what might a patient describe or feel? So number one would be swelling, and the swelling can happen anywhere in the legs. It can be only in the feet, or that swelling can move a bit higher into the ankles or even to the up to the knee or thigh in some situations. And that swelling and extra fluid can lead to weight gain. Patients may feel very tired. There may be a change in the appearance of the urine due to the presence of protein that is sometimes described as foamy or bubbly urine. And in addition to feeling tired, patients may not feel very hungry. And so this cartoon on the right that I like to show when we're discussing nephrotic syndrome, I think really kind of captures all of the different symptoms. And so here you have an individual that has a lot of swelling in the legs. And so we also call that edema. And peripheral edema refers to the legs or the arms. And so we can see that the legs here are swollen. And here's a urine sample that has a lot of protein in it. And I like this cartoon because there's a dog here that is drinking this protein-rich urine and kind of imagining growing muscles here. And then here is a kind of zoomed-in view of what one of the blood vessels might look like. And so we can see that the blue dots, which are the protein levels, there's not that much of that. And so nephrotic syndrome leads to low protein levels in the blood. And then we can see many of these yellow circles or fat droplets, and this refers to the high levels of fat or cholesterol in the blood that can also be a sign of nephrotic syndrome. And the reason that patients have these high levels of fat or cholesterol are because the liver actually senses that there's not a lot of protein, and in response to that tries to make more protein. And while it's unable to do that, it does also make more of everything else that it makes. And liver is one of the producers of cholesterol. And so that's why in patients with nephrotic syndrome, we have high levels of cholesterol or fat in the blood. And so based on these symptoms and findings, it makes sense that the best way for us to identify nephrotic syndrome is to not only obtain a history from the patient and perform a physical exam to look for the swelling that might occur, but the blood tests and urine tests are incredibly helpful because a blood test can help us look for abnormalities with the kidney function, and the urine test can help us find the level of protein and uncover high levels of protein in the urine. And the blood test can also help us to measure the levels of cholesterol or fat in the blood, as well as the levels of protein in the blood, which should be low in patients that have nephrotic syndrome. And so there's a question about the combination of the use of ACE inhibitors and angiotensin receptor blockers. There's not a lot of data to support that. And at the end, we'll talk a bit about clinical trials, and there are many ongoing trials for nephrotic syndrome. Once you are diagnosed, another question asking how often should you have blood and urine tests. And so that really depends on what is the cause of the nephrotic syndrome, or what is the disease, and what is the treatment plan that is being administered. And then based on that, the kidney doctor would decide what is the best follow-up plan. And so that can range anywhere from repeat urine and blood tests in a few months, or repeat urine and blood tests in a few weeks. Again, it depends on the disease that is causing the nephrotic syndrome, how severe it is, and what is the treatment plan that is being pursued. Next slide, please. And so again, to review, what are the tests that we as kidney doctors do to try to uncover or find nephrotic syndrome? And those are summarized in the flow sheet on the right-hand side of the slide. And so again, urine tests are incredibly important to look for the presence of protein in the urine. The blood test can also show us not only levels of protein and cholesterol, but also how well the kidney is filtering. And many of you are probably familiar with the number that we use to do that, which is called the creatinine. And the creatinine helps us estimate how well an individual's kidneys are filtering. And then finally, the kidney biopsy we would perform in patients with nephrotic syndrome to help us uncover what is the disease that is causing the nephrotic syndrome. And then we would have to make a decision about whether or not this is a primary or a secondary nephrotic syndrome, and then come up with a treatment plan that is the best for that individual patient. And so there was another question about the protein is low because the filter does not work effectively. What causes the protein to be low? And so there are likely many different factors that lead to low protein levels. But in this one important explanation here is that when you are losing a lot of protein in the urine, then that leads to a decrease in the protein levels in the blood, because the protein cannot be made fast enough to keep up with that. And the low levels of protein are also potentially a marker of whatever the disease process is that is going on that is causing that nephrotic syndrome in that individual. Next slide, please. So now I wanted to transition to nephrotic syndrome and transplant. And so nephrotic syndrome, the definitions and the causes are actually the same before and after kidney transplant. And it can be very important to try to understand that, because if someone has nephrotic syndrome prior to kidney transplant, depending on the cause, it is possible that that same disease can cause nephrotic syndrome after transplant. And depending on that cause, there may be things that we as kidney doctors and transplant kidney doctors might be able to do to try to prevent the risk of that nephrotic syndrome happening again. And this graph here is showing us that unfortunately kidney transplant don't last forever. And each curve here represents kind of a different block of time. And this is data from Europe as going back as early as 1986. And again, the point of the slide here is to show that this is a survival of the kidney transplant on the y-axis and the time after transplant on the x-axis. And as we move through time, kidney transplants unfortunately fail. And so it's important for us as kidney transplant doctors to try to maximize the life of the kidney transplant by looking for diseases that may be happening in the kidney transplant and syndromes such as nephrotic syndrome. Next slide, please. And so why do kidney transplant fail? And there are many reasons for that. And so the arrow that I pointed to here is a yellow box that has inside of it recurrent or de novo glomerular disease. And so why am I highlighting that one? We're talking about nephrotic syndrome today, and nephrotic syndrome, as we discussed earlier, is a reflection of injury to the kidney filtering unit or the glomerulus. And so recurrent means that the patient had glomerular disease prior to their kidney transplant, and they're having that same disease again in their kidney transplant, whereas de novo refers to a patient that did not have nephrotic syndrome or injury to that kidney filtering unit prior to transplant, and now is having the nephrotic syndrome after transplant. And glomerular disease, as someone had asked before, can be a nephrotic or a nephritic syndrome. And here I'm really focusing on the development of nephrotic syndrome after kidney transplant. Next slide, please. And so who is at risk for nephrotic syndrome after transplant? And so as a kidney transplant doctor, I'm very interested to know what a patient's kidney disease was prior to kidney transplant, or what was the disease that caused their native kidneys to fail. And so if someone has a disease such as FSGS prior to kidney transplant, then I would be concerned about the risk of nephrotic syndrome after transplant. And so very important in an individual like that to pay very close attention to the amount of protein in the urine. But not only patients like that, I check protein levels in the urine regularly for my patients with kidney transplant, basically every time that they have blood work and urine tests that are performed. Diseases that affect the kidney, like lupus and diabetes, can also cause nephrotic syndrome. And so if I know that somebody has that, then I would for a patient with diabetes, for example, try my best to improve their sugar levels in the blood to try to prevent the development of a secondary nephrotic syndrome in the kidneys. And so I might try to adjust some of the diabetes medications in conjunction with the help of a diabetes doctor, such as an endocrinologist, to try to get the best sugar control for a patient that has diabetes. There are certain medications that can cause a nephrotic syndrome. There are certain antibiotics or pain medications, such as non-steroidal anti-inflammatory medications. And so that's why it's very important for patients with kidney transplant to discuss all medications with their kidney transplant physician prior to starting new medicines that are not prescribed by them. And then finally, if you remember back to that graphic that I showed you showing the causes of primary and secondary nephrotic syndromes, infections are an important cause of nephrotic syndrome. And so as kidney transplant doctors, it's important for us to look for these infections and to treat them appropriately whenever possible to try to avoid the development of nephrotic syndrome post-kidney transplant. Next slide, please. And so a slide about FSGS, as we had mentioned that before, FSGS again is focal segmental glomerulosclerosis, which essentially means that the kidney filter or the glomerulus becomes scarred, which makes it difficult for the kidneys to filter out waste, and this can lead to kidney failure. It is a common and important cause of primary nephrotic syndrome, and after detection of protein in the urine and the other features of nephrotic syndrome in the blood, or that may present with the patient, such as swelling in the legs, a kidney biopsy would be required for diagnosis. And then on that biopsy, we would not only see the scar of the kidney filter, but we would also see the injury or flattening of those podocytes that are very important for effective filtering by the kidney. Next slide, please. Molly had mentioned earlier that I'm involved with a group called Tango, which is an international research group, and that research group was formed a few years ago to try to better understand causes of kidney injury in individuals after kidney transplant. And so this is a visual abstract from one of the nephrology journals, the clinical journal of the American Society of Nephrology, that summarizes the findings of one of our projects as part of the Tango group. And so again, Tango stands for Post-Transplant Glomerular Disease Project. And this particular study looked at the recurrence of FSGS in patients after kidney transplant. So essentially what we did was each of the transplant centers that were involved in this study found patients within their center that had a diagnosis of FSGS prior to transplant, and then developed FSGS again after their transplant. And our research project tried to identify what are some of these risk factors that might help us understand who is at risk to develop FSGS after transplant if they had it prior to transplant. And then you can see in this blue box that is outlined that some of the risk factors that we found were older age, white race, BMI or body mass index, and patients that had their native kidneys removed prior to kidney transplant. And so it's important for us to try to better understand the pattern of who is more at risk for FSGS, because that might allow us to identify patients that might need different treatment options or might have a different follow-up course after their kidney transplant. Next slide, please. Even though our study found that older age was associated with a risk of FSGS occurring again after transplant, this larger study performed a few years ago that included all forms of glomerular or kidney filter injury found that the risk of recurrence was actually lower as individuals become older. And so I included this graph just to show that we have a lot to understand and to continue to learn about causes of nephrotic syndrome after transplant and how we might prevent the recurrence of nephrotic syndrome in patients that might be at higher risk. And so the first step to try to do that is to try to understand who are the patients that are at the highest risk for developing this. And since we don't really know that, that's why it becomes incredibly important to do regular screening for nephrotic syndrome by checking the protein in the urine as well as in the blood, along with the creatinine or an estimation of the kidney function. Next slide, please. And so why is it so important to find and treat nephrotic syndrome? Nephrotic syndrome can lead to other problems such as blood clots, which we mentioned. The risk of infection may be higher. Nephrotic syndrome might lead to the immune system not working normally. And you can see here listed some other important problems that may develop. And what is, I think, highlighted here and what is probably the most important if we're just thinking about the kidney transplant is that untreated, if a nephrotic syndrome disease continues, then that could potentially cause the kidney transplant to fail. And so our job as transplant kidney doctors is to try to prevent that and do everything that we can to maximize and prolong the life of the kidney transplant and doing that in a way that is safe. Next slide, please. And so what can we do to protect the kidney transplant, or what can you do if you have a kidney transplant? If you have had nephrotic syndrome prior to receiving your kidney transplant, it's important for your kidney transplant doctor as well as your care team to know that, because you may be at higher risk for developing nephrotic syndrome again after kidney transplant, and your medications may be adjusted slightly if your transplant care team has that information. It's very important to continue regular follow-up with your kidney transplant team, of course, not only for nephrotic syndrome, but to ensure overall health as well. And specific tests would include regular blood and urine tests to look for early signs of kidney injury and nephrotic syndrome. And so we would be looking for any development of new protein in the urine that was not there before, or a drop in the kidney function that can be measured in the blood, or a drop in the levels of protein in the blood, along with measuring the cholesterol levels, which is done routinely, but any change that is unexpected in those levels may prompt further investigation to look for the development of a nephrotic syndrome. Next slide, please. And so how can I treat nephrotic syndrome? So there are certain medicines that we can use to treat the symptoms and to try to keep the damage to the kidneys from getting worse. We can use medicines called diuretics or water pills to try to get rid of that extra water if someone develops swelling. That can also help improve the blood pressure. Blood pressure and cholesterol medicines can help prevent heart attack or stroke. And often changing how one eats can also help with symptom management, and specifically the amount of protein, salt, and fat can be important in patients that develop symptoms and signs of nephrotic syndrome. Additional treatments might depend on whether or not this is a primary kidney disease or a secondary kidney disease. And so again, coming back to that example of diabetes, if I think that a patient has nephrotic syndrome because of diabetes, then my focus for treatment would be to improve the sugar levels in the blood. Primary treatment for a disease like FSGS or focal segmental glomerulosclerosis might include medications to decrease the inflammation or the activity of the immune system that might be causing the process. And so an example might be using steroids such as prednisone. Next slide, please. And so the key takeaways here are: 1, nephrotic syndrome is caused by primary or secondary diseases that harm the filters in your kidneys. 2, nephrotic syndrome can happen even after a transplant and can harm your new kidney transplant. And 3, close follow-up with your transplant nephrology team is incredibly important and necessary to look for early signs of kidney injury and nephrotic syndrome. So I wanted to address a few questions in the chat. One I see here is, so if I have a kidney transplant, the native kidneys remain in me. I thought they would be removed. And so the majority of the time, the native kidneys do remain in place in patients that have a kidney transplant. There are certain situations in which the native kidneys would be removed. One would be if they have infection. Another would be if they're causing some other problem to the patient. But in the majority of patients that have kidney transplants, they also maintain their native kidneys. And the next question I see here is, does exercising help or exacerbate? I read moderate cardio, no heavy lifting, light weights, high reps. This would be a question that's individualized to the patient. In general, physical activity is recommended and beneficial. Heavy lifting, again, would be a patient-to-patient discussion. Nephrotic syndrome does not preclude someone from doing heavy lifting or dictate the type of exercise regimen that someone should perform or should not perform. And so I'm gonna stop there. That's the end of our slides here, and can try to answer some additional questions or comments that anyone might have.
Well, thank you, Dr. Farouk, for leading such an excellent webinar this afternoon. So since we've already started with some of the Q&A, let me ask some of the questions that were submitted ahead of the webinar. So somebody asked, is nephrotic syndrome a diagnosis? Will a doctor tell me I have nephrotic syndrome, or will they just tell me the symptoms I'm showing, such as proteinuria?
That's a great question. This would be, individual to the specific doctor. For my patients, I would tell them that they have the signs and symptoms of nephrotic syndrome, and then I would discuss with them what the possible causes would be, along with what my plan would be to try to confirm the diagnosis. And then that diagnosis would lead to a discussion of the most appropriate and best treatment plan for that patient.
That's a great explanation. So someone else asked, if I think I have nephrotic syndrome, should I be asking my doctor what the primary cause could be?
Absolutely. And if anyone has nephrotic syndrome, as kidney doctors, it is our job to try to understand what is the cause. There are no 100% definitive tests that tell me that this is the cause and I'm 100% sure. But what I can do is use information from the biopsy as well as other information that I can gather from the patient and other lab tests to feel as confident as I can about what the particular cause is. It's very important to try to identify the cause as best as I can, again, because that is what is going to help me come up with my treatment plan to try to pause or reverse the nephrotic syndrome disease that might be going on.
Great answer. So somebody else asked, is it possible to have nephrotic syndrome and not lose your kidney?
It's absolutely possible to have nephrotic syndrome and not lose your kidney. That's why we do have treatment options for the different causes of nephrotic syndrome. Some of our diseases that I shared with you in the slides are more responsive to treatment, I would say, than others. So it's hard to say just with kind of nephrotic syndrome alone. Unfortunately, some patients that develop nephrotic syndrome may progress to end-stage kidney disease. However, that's not all patients. That's why early detection is important, because oftentimes if we do find the disease process a bit earlier, it may respond a bit better to treatment. Again, that also is not always the case. And so it's really a patient by patient individualized basis and a conversation that we encourage patients to have with their kidney doctors. Because again, everyone is different and it's hard to just say for everyone who would respond to treatment and who would not, and who might need a kidney transplant and who might not.
Well, going off of that question, somebody else asked about treatment specifically related to FSGS. So the question is, how is FSGS treated and can it come back?
So FSGS is treated, again, it depends on the patient that it has FSGS and if they have other medical problems and which treatments would be safest for them. But many kidney diseases and diseases that injure the glomerulus or the kidney filter are what we call driven by activity of the immune system. So the medicines that we use in general are medicines that are called immunosuppressants, or medicines that decrease the activity of the immune system and hopefully should slow down that disease process. And so generally, the first line, what we would say for treatment for a disease like FSGS would be a steroid, such as prednisone. And we might watch the response to that. And if there is no response, then there are other stronger medicines that suppress the immune system that we may use. We have to be careful because immunosuppressants are, again, suppressing the immune system, which we need to fight infection. And so there is always that risk when we use those medicines that there may be an infection that develops. So we have to be very cautious and make sure that patients have appropriate follow-up while they're using these medications.
All right, and earlier you talked a little bit about swelling. So we had a couple questions about that. One person asked, does fluid buildup from nephrotic syndrome cause sudden changes in weight? And similarly, somebody else asked, why does nephrotic syndrome cause the face to swell?
Yeah, so the swelling in nephrotic syndrome is thought to be due to several different causes, and so I'll share two of them. So one of them is because of the loss of protein, we lose the protein in the blood, and so when we have low protein levels in the blood, protein actually helps to keep fluid kind of out of areas where it would cause swelling. And so when we lose the protein, the fluid can actually kind of leak out, and that's what causes the swelling in the legs and in the eyes and can make the whole face kind of look puffy. The second reason is that in patients that have a lot of protein in that urine, that protein actually tells the kidney to reabsorb or hold on to more salt. And so there's extra salt that is put into the body because of that, and that also contributes to the swelling. And that's why, in addition to water pills and diuretics, we also encourage patients to try to limit the amount of salt that they take, because that can actually make the swelling worse.
Thank you for that.
Molly, I'm seeing several questions in the Q&A
Yeah,
box. Did you want me to try to answer some of those?
yeah, absolutely. So I can certainly read some of those off. One person said, I work with kidney dialysis patients who said that their kidney was damaged due to a car accident. Can nephrotic syndrome be caused by an accident?
That's a difficult question to answer because it would really depend on what type of damage was done to the kidney as a result of the car accident. That would require evaluation that we discussed. So the blood test as well as a urine test, and that would help us answer that question of whether or not there was a development of nephrotic syndrome. In general, that trauma is not a common cause of nephrotic syndrome.
Good to know. You talked a little bit earlier about some of the genetic causes of nephrotic syndrome. So somebody asked, is it recommended that the patient has genetic testing?
So it is not routinely recommended that the patient has routine genetic testing. Depending on the family history and other patient-specific characteristics or features, we may suggest genetic testing. And again, that depends on which cause of nephrotic syndrome is most likely in that patient, but we do not, as a screening test, perform genetic testing, as at this time that information is not particularly helpful.
Thank you for that explanation. So we talked a lot about kidney patients this afternoon, but somebody has a question about donors, and they asked, can kidney donors also develop nephrotic syndrome?
That's an important question. The data that we have so far suggests that kidney donation is safe, and that the risk of the development of end-stage kidney disease in kidney donors is not that different from the general population. But again, every donor is different. So is it possible that one of these causes of nephrotic syndrome could develop? The answer is yes, but it would not be related to the process of kidney donation. It would be a factor that would be related to that individual patient. However, I would like to add that we do perform rigorous testing for kidney donors prior to donation. For example, we look very closely for history of other medical problems. We check for many different infections that can cause nephrotic syndrome. We ensure as best we can that our donors do not have diabetes. However, it's possible that, say, after kidney donation, a patient develops diabetes, and that diabetes in theory can also lead to nephrotic syndrome, as we discussed. However, if there were any flags at the time of donation that this patient would be at risk for nephrotic syndrome, then of course we would not clear that patient for donation, as that would be unsafe.
Thank you for that answer. So someone else asked, how is chronic kidney disease related to nephrotic syndrome? Is one different from the other?
That's a great question. It's just the terminology is a little bit different. So chronic kidney disease is a more general term. Chronic kidney disease refers to a decrease in the kidney function over a period of at least 3 months. Nephrotic syndrome refers to what is happening at the level of the kidney and what is the disease process that is actually going on. And so nephrotic syndrome can cause chronic kidney disease, but not all causes of chronic kidney disease are due to nephrotic syndrome. So it's kind of like all squares are rectangles, but not all rectangles are squares.
That's a great analogy. So somebody else asked, are there additional risks from COVID-19 for those with nephrotic syndrome?
That's an important question. So of course, COVID-19, we are learning information every day, and we do not know everything about the virus. However, unfortunately, COVID-19 has shown that it can be a cause of nephrotic syndrome in some patients. And so there have been reports that have been published about patients that have developed a secondary cause of nephrotic syndrome that we think is due to COVID-19.
That's very good to know. Someone else asked, if a patient has a kidney transplant due to end-stage renal disease, what can they do to prevent nephrotic syndrome?
That's a great question, and I wish I had a better answer than what I'm going to say. Unfortunately, we don't have any medicines or anything that we can do to 100% prevent the development of nephrotic syndrome. What we can do is try to understand as best as we can the risk factors that someone might have, and if someone has many risk factors, then we might do screening tests a bit more regularly than what we would do normally. So an example of that would be, say that someone that is on dialysis and had kidney disease because of FSGS, and then they get a kidney transplant, I might start looking for protein in the urine even earlier than I might in someone else. And so I would remember that for kind of the duration of that patient's kidney transplant. And I just want to answer another question that was asked again about whether or not polycystic kidney disease can cause nephrotic syndrome. Polycystic kidney disease is not a common cause of nephrotic syndrome because it does not directly affect the podocyte or that filtering cell. However, in patients with any reason for kidney disease, if they're approaching end-stage kidney disease, regardless of the cause, there may be large amounts of protein in the urine. But in general, polycystic kidney disease is not one of the diseases that we associate with as a common cause of nephrotic syndrome.
That's great to know. So speaking about protein spilling, somebody asked, is there medication to decrease the protein from spilling over or decrease the protein in urine before it becomes nephrotic syndrome?
That's also a great question. And so in our patients in whom we detect protein levels, whether they be low or high, we do start them on medications called ACE inhibitors or ARB receptor blockers. Those are medicines that are also used in patients prior to kidney transplant who may develop some level of protein in the urine. And so even if patients have low levels of protein that are not at the level to be nephrotic syndrome, that is a medication that we use that has been shown to decrease or slow down the progression of the kidney disease. And that can be used in patients that have either primary or secondary nephrotic syndrome.
And that's a great transition to another question we received prior to the webinar. Somebody asked, what is the difference between ACE inhibitors and ARBs, and which is the preferred treatment post-transplant?
So they are both excellent, and both have been shown to have similar effects. They basically work in different parts of the same pathway, and so they are both trying to prevent the same end result. And so sometimes ARBs may be used instead of ACE inhibitors if a patient had a adverse effect with ACE inhibitors. And so again, this is a personalized decision for the patient. So there's really no efficacy difference between the two.
That's good to know. Somebody asked about exercise. Specifically, does exercise help or exacerbate nephrotic syndrome?
Yeah, it's difficult to comment on exercise overall. Exercise, I believe, is a very patient-specific plan, and what exercise plan is right for that patient. Speaking in general, exercise should not harm patients with nephrotic syndrome if they otherwise feel well enough to do so. But if there is a lot of swelling, it may be challenging for patients to be mobile. But there's nothing to suggest that exercise is harmful.
Great.
I see a question about EBV infection causing FSGS and nephrotic syndrome if you had a transplant. So unfortunately, many viral infections have been reported to cause secondary nephrotic syndrome and FSGS. EBV has been reported to do so. So that is possible.
Thank you for that explanation. Somebody else asked a question, someone who's on PD dialysis. They said, I'm on PD, so should I be concerned about nephrotic syndrome?
In general, patients that are have already initiated dialysis, even if they have some what we call residual kidney function or they still make urine, generally we would not think about a development of a new nephrotic syndrome as much for those patients. The risk is likely not as high.
Great. So somebody else asked, in sort of wrapping up here, where can I go to learn more about nephrotic syndrome?
So there are resources from such as NephCure that have some resources. I don't have a particular resource off the top of my head, though I do believe that the American Kidney Fund, I think, has some literature about nephrotic syndrome and some more descriptions.
Thank you. And one last question, where can I learn more about kidney transplant?
So that's another great question. I'm sure that the American Kidney Fund also has some resources about kidney transplantation. And there are also resources from the National Kidney Foundation as well as the American Society of Nephrology. There should be sections that address kidney transplantation. And I think the best resource would be if you are currently seeing a kidney doctor, to ask them where is the closest kidney transplant center, and they likely also have resources that can be very helpful to learn more about the kidney transplant process. And the kidney transplant process starts with an initial visit with the transplant care team, which would include not only a transplant kidney doctor like myself, but also a transplant kidney surgeon, a transplant coordinator, dietitian, social worker, and all of those resources together, I think, can provide a lot of information for a patient that is interested in learning more about kidney transplant and trying to decide whether or not to move forward with the next step, which would be evaluation of the patient.
Well, thank you so much, Dr. Farouk. We really appreciate all your great answers to all of those questions. And so this concludes today's webinar. This webinar was recorded and will be made available for viewing on our website, kidneyfund.org/webinars, within the next 1 to 2 weeks. Our next webinar will be on diabetes and kidney disease as part of AKF's Know Your Kidneys campaign, sponsored by Janssen. The webinar will be held on Wednesday, November 4th, 2020, and hosted by Dr. Christian Mendy, who is board certified in nephrology, internal medicine, and clinical hypertension. Registration is now open. Visit kidneyfund.org/webinars for more information and to register. When the webinar ends, please do not close your browser window. Your browser window should open a new tab to a webinar satisfaction survey. We ask that you please complete the survey. Your honest feedback will help us make our webinar program the best it can be. Thank you for joining, and we hope to see you again.